Good afternoon, ladies and gentlemen. My name is Zilu. I'm a current PhD student with the school, and I'm working on tobacco research. So it's very much in line with the theme of today's topic, and therefore it is my great pleasure to be your MC for the event. Senior Medical Consultant, Center for Addiction and Mental Health, Professor, Department of Psychiatry, University of Toronto, Canada, Dr. Peter Selby. Vice Dean Practice, NUS Sosui School of Public Health, Associate Professor Jason Yap. Distinguished guests, colleagues, and friends, a very good afternoon to you, and a warm welcome to the 12th Public Health Thought Leadership Dialogue presented by the Sosui School of Public Health. Tobacco use today kills about 5.4 million people a year worldwide, and that is an average of 1 person every 6 seconds, accounting for 1 in 10 adult deaths in the world. The impact extends to non-smokers as well, harming both their physical and mental health through exposure to secondhand smoke. Taken together, tobacco has an enormous impact on public health. Most of tobacco's damage to health does not become evident until years or even decades after the onset of use. Tobacco use is rising globally, and we have yet to see the peak of the tobacco-related disease and death. Quitting smoking is not easy. However, it is definitely possible. In Singapore, there are many programs supporting tobacco-free lifestyles, and one of the key challenges faced by tobacco users is, how do you quit for good? With that, we very much look forward to hearing from today's guest speaker, smoking cessation expert Dr. Peter Selby, on overcoming challenges with smoking cessation. I would now like to invite the Vice Dean of Practice at Sosui School of Public Health, Associate Professor Jason Yap, to say a few words and introduce our distinguished speaker for the session. Professor Yap, please.
Dr. Selby, friends, happy to see all of you here today. This is our Public Health Thought Leadership Dialogue, which we hold from time to time. What we find important, being the School of Public Health, is that we have been shifting in the way we perceive health, healthcare, and so on. I'm a medical doctor, so I grew up in healthcare, and my friends know I love the number 3. So the one triad that we public health people are always talking about is primary, secondary, and tertiary prevention. Healthcare is largely about tertiary prevention, preventing complications, helping people live well, right, and helping people to live well as well. Secondary prevention has been coming on as part of this process because we're screening for conditions. And now if you see what's happening in Singapore, we are placing a lot of emphasis on primary prevention, healthier SG, trying to get lifestyle prescriptions and so on. But for today, there's another triad that we've been trying to teach our undergraduate students as well, which is the triad of biomedical, of the determinants of health. What we tend to focus on in healthcare is the biomedical determinants, the virus, the what causes that obesity, and all those things, right? But we've been expanding our curriculum to have a greater focus, greater emphasis on the socio-ecological determinants, one step before that, right? The environment, the economy, transport, housing, and all those other things. What I've been thinking about the past couple of years, actually, is there is a third part to it, which is commercial determinants of health. The thing about commercial determinants is that it is an inevitable consequence of the fact that we have to make a living, that we have to have economy, we have to produce in order to keep our people fed and well, and so on. There's some part of it. I mean, we all, Singaporeans, right, we all work very hard. That's actually a commercial determinant of health because you work too hard for profit or for policy or for whatever other reason. It's not a good thing, right? But what I have not been able to figure out, right, is the tobacco industry. Right? Arguably, McDonald's, fast food, that's not a good thing. But as I was told very forcefully when I was doing my Master of Public Health a long time ago, there's no such thing as junk food. There are junk diets, right? So a McDonald's burger is okay. It's just how many do you take it and over what period of time. So there is some some redeeming quality even in fast food. There is some redeeming quality in sugar-sweetened beverages. There is some redeeming value in quite a lot of different industries, even though they may cause harm and they may cause issues of health. But I find nothing in the tobacco industry. I cannot think of why on earth we would even allow such a thing to happen. Without going into history and the historical evolution of the colonialism and what else, which seems to be a common tag these days, the tobacco industry is one that we really need to pay a great emphasis on. I think one important thing we have to do is to try. I've been well educated by Yvette that we have to try to prevent young people from taking up smoking, because tobacco industry is the only one that actually kills its customers consistently, and they have to replace it. So they go after our young people who are young enough to take up the habit. But there are other people should not be neglected. How do we help people to stop smoking? And I think today's talk is very appropriate because it fills in that space, right, where we have to get current users off the habit, get them off and stay off. I think what I liked about Dr. Selby's approach is that tobacco is a worldwide problem for the last couple of centuries, right? And we've been applying a lot of different approaches to it. Over time, we use the financial instrument of taxation, which we just did again in Singapore. We use psychosocial approaches to it and so on. But the application of technology, as in what's latest available today, that's a very interesting angle. And so I look forward to Dr. Selby's talk. I'm sure we'll all learn a great deal. And as I said, I'm going to get out of the way and give the floor to Dr. Selby. Thank you.
All right. Thank you very much. Can people hear me? Yeah? Okay. So I tend to speak very quickly, so if I want to ask the audience, if I'm going too quickly, just put your hand up and I'll slow down. And I tend to do that when I get excited, so I'm really excited to be being here. So interestingly enough, I'm one of these people who started working in family medicine, and I realized that we were doing, as you said, this kind of secondary prevention, and it wasn't satisfying. But then I also got interested in the disparities, and I started focusing on people with substance use disorders and addictions, and immersed myself as part of that, as part of my practice. And as part of that, did extra training, and therefore I also became part of the Department of Psychiatry. So we had sort of mind and body. But then there was something missing, because here I was at the front line trying to fix things, but there were other determinants at a higher level that were determining what was happening. And so public health became the next piece of it. So actually, I work in 3 faculty. One is family medicine, psychiatry, and public health. Because if we're going to tackle big issues in society today, they need to be mind-body society kind of issues. So, and as I was working with substance use, I initially started focusing on things that were like the big issues like opioids and things like that. But right in front of me was this other bigger addiction called tobacco that was everybody's business but nobody's business. And so I really immersed myself since about 2000 to really figure out how do we as a society pay attention to something that kills as many people as it does and continues to do so. And what is our response to it? So that's how I come to this work. And so I'm very pleased to be here. Thank you so much for inviting me. Thank you to Dr. Van Eyck, I think I'm saying that right, who's our moderator, and to all of those who helped organize. Sandra, who's on her way here, Pang Wee, Li Zhang, and Amanda. So these are my disclosures, and I have no connections to the tobacco industry, vaping industry, food industry, or alcohol or vaping industry. My connections to any pharmaceutical company is because we buy medications for the population in an open tender process, and then we distribute it. And so because we do that, we get it at a discounted rate, so I'm describing to you that is a potential conflict. But otherwise, there are no other conflicts. So I've got about 4 things that I want to cover today, and I hope you'll find that helpful. So I'll position myself. I'm going to be talking at this interface between clinical and population health. One of the first disclosures I will say to you is that if you want to reduce the prevalence of tobacco, you need to do all the population things. You need to reduce demand, and you need to reduce supply. So you could do things like taxation, minimum pricing, plain packaging, getting rid of additives, all of those things, warning, all of that has a huge impact in one fell swoop in reducing prevalence. The issue becomes, as we've seen in tobacco control, that in itself can create an inequity, because what happens is the people who are most responsive to it, in most of where the epidemic has gone, are the people who are educated, people who have means, and so the current population of people who smoke are those who can least afford to smoke. And they're kind of not as responsive to these population level kind of interventions, and so you create this disparity. And that's where I think clinical medicine can come in as a mitigation strategy. You are not going to reduce your prevalence of smoking by just simply having more treatment. But what you're going to do is help people out of that addiction. So that's how I balance it out. One cannot work without the other if you want to actually have an overall impact on your population. And not just a prevalence number, but an overall health impact. So that's how I'm going to talk about. And so we're going to talk about how can we better engage smokers in quit services? What does it take? How can we improve quit success for those who intend and try to quit? And should we? There's some arguments that we shouldn't bother trying to improve the success of a quit attempt. What we should be doing is getting more and more people to make quit attempts and creating the structure that they quit, but not focus our efforts. So there's a lot of debate around that. And what are some new innovations or approaches to improve smoking cessation outcomes? And what are some ongoing challenges, especially with vaping now coming on the scene? I understand it's illegal here to vape, but it is making its way in the world, and there's a lot of debate around it. So I'll talk about it. And really, I'm not trying to say this is what you should be doing here, but give you some things to think about and reflect and think about as we are listening to this. Ask yourself, how would this apply in the situations like in Singapore and in the situations from where I work? So one model that we've used to always look at our services, are people familiar with this model of Susan Mickey? So it's called the COMBI model, that any behavior, and we look at for any behavior, whether you're going to approach people who are smoking, physical activity, whatever it is, any behavior change. Basically, a behavior is the sum of impacts of somebody moving either towards something or away from something. That's one way to think about a behavior, right? It's an observable action towards something or away from something. What makes that happen is interaction between the capability, the motivation, and the opportunity, right? So if I find myself living in a place where there's no smoking, then the opportunity to smoke is a lot less, even if my motivation is low to quit. It's just I don't have the opportunity, so I don't smoke. How does this happen in our health system? When somebody gets admitted to a smoke-free facility, the opportunity to smoke drops, right? So even though there's the motivation, they don't smoke because there isn't the opportunity. Does that make sense? So as we are looking at people and improving cessation, we need to think about how these interact. So this is the guideline, and I think you can apply this behavior change wheel at policy levels, at clinic levels, at a macro, meso, micro level, and we help our patients also apply this. So if they are quitting smoking, we ask them what are their micro level policies that reduces the opportunity to smoke, that increases their motivation to quit, and increases their ability to quit. So this is evidence-based. So we take that evidence and then apply it to the patients. And patients can buy into it because they realize, if they are trying to quit smoking when there are cigarettes in the home, they're half as likely to be successful. So policies that make their living space smoke-free is going to double their chances. So those are the ways in which we need to go beyond telling people, well, you should just be motivated and just quit. We go beyond the motivation. We look at the environment in which they find themselves. And this is very aligned with the, with sort of agent-host environment kind of thinking in public health. We're bringing it into clinical medicine as well, because we need to think of these multiple determinants of how people change. So how can we improve quit success for those who intend to try to quit? So I told you about a model by which we can design a better intervention for people. Obviously, medications. Now, medications is one piece of the puzzle, and it's what it's a very interesting, I think Dr. Ibs talked about this whole idea that we work in the commercial gain, and there's always a push. Here's one thing we need to recognize. Most ever smokers who've quit have quit unaided. So most ever smokers who've quit have quit unaided. The question remains as to whether the remaining smokers who continue to accrue risk from a really dangerous product that has 7,000 chemicals, 60 to 70 known carcinogens, and are dying from the smoke, do you just let them go, or do you actually intervene early to remove that exposure so they don't develop the complications, right? People smoke for the nicotine but die from the smoke. So if we are interested in overall health, what is that trade-off we are willing to do? So medications are an interesting one. Why? Because nicotine, if nicotine is what gets people addicted, we know the brain chemistry where nicotine acts. We have identified the nicotine receptor, which is very interesting. Nicotine receptors were identified way before the receptors for cholesterol and other medications were identified. But look at the investment that has occurred for those conditions compared to treating something that kills as many people, right? As it stands now, you have only 3 medications approved: nicotine replacement, bupropion, and varenicline, which is a partial agonist, for smoking cessation. But look at the formulary for how many drugs that are there for lowering somebody's cholesterol or antihypertensives. So that's a societal value that we have not paid attention to engage people in creating treatments for this population. But here are medications. They do work. And if you look at the Cochrane reviews, they roughly double the chances of quitting. So it is part of the system. It is not the only system. And they have limitations, but they definitely are roughly doubling the odds that somebody will quit. So we should be giving people any one of these medications, if safe to do so. So the most effective first-line treatment is a partial agonist called varenicline. And here's the thing. It's not available now. It's been pulled off the market. Why? Because they found nitrosamines. Anybody want to guess where else you find nitrosamines in 10 times the amount? In cigarettes. But nobody's pulled a cigarette off the market. In Canada, they had a recall of cigarettes recently. Why? Because the cigarettes burnt too quickly and were a fire risk. Well, cigarettes are a fire risk even if they don't burn too quickly because they smolder. So society has got a weird way of regulating, but we need to think about this because we've pulled an effective medication. The most effective medication is now not available to a lot of the world. But cigarettes continue to be available. So what are the policy levers and how are we helping regulators understand this? You're not giving varenicline to a non-smoker. You're giving people who smoke varenicline. So that's one of the things that you're currently facing this, but it is one of the most effective. So if it's not available, the evidence suggests that combining a patch, which gives nicotine in a low level to somebody, plus something that when the craving hits can be mitigated, which is a short-acting NRT, which is usually a lozenge or an inhaler or nasal spray or a mouth spray, and in some countries a gum, can be used to help people mitigate. And it has sort of the same kind of effectiveness as varenicline. So you're not stuck. There are options. When you take a look at varenicline meta-analyses, and these are kind of old ones, roughly the takeaway message is that compared to other interventions, the improvement in success, the baseline quitting unassisted is about 3%, 3 to 5%. you add a medication, even if they don't do intensive counseling, you are increasing that success tremendously. The biggest problem is people will say to you, I don't want to put a chemical into my body to quit smoking, which is really interesting because when we educate them that they are taking 7,000 chemicals with every cigarette, 10 to 20 times a day, what about something that will eliminate that completely? So we have to do a lot of education. There's a lot of myth amongst the population, even healthcare providers, that we have to work with. But here's the evidence that if you actually use medication, you can get a very high quit rate. The biggest problem with it is with varenicline is that there are some immediate side effects, and you have to educate people on how to manage side effects. And they aren't usually tolerable for them because they can tolerate their cigarettes. They'll take the side effect from the cigarette. They've got used to the morning cough. They're used to the phlegm. They're used to all those things. But they're not used to a new medication. So in prescribing medications, one of the key issues is to educate patients properly and how to use it, how to manage side effects, and not to get sick. Having said that, it's not available right now in many parts of the world because of this manufacturing issue. Nicotine replacement is. Now, unfortunately, the slide got cut off, but the first column is the patches, the second one is the gum, the third one is the lozenge, and the fourth one is the nasal spray. But basically, this is one of the most tolerated medications. The intolerance comes from topical issues of nicotine. And we have found that in our patient population that we run, that the problem is most people will not use the medication for the duration of what is required. They'll only use it for a couple of weeks. So what this means is, again, educating and helping people understand that the duration of treatment is critical. Another medication, bupropion, which is accidentally discovered, it interferes with the experience of smoking, so people kind of feel full quickly. They don't like the taste of their cigarettes, and they learn very quickly not to smoke. Very cheap medication, generic. Again, really effective out there. Can it be prescribed by anybody? In Canada, it can be prescribed by a dentist, it can be prescribed by a pharmacist, it can be prescribed by a family physician and nurse practitioner. And it's essentially, with education, anyone can prescribe this, mostly well tolerated. And again, you can see how it does better. So these are the kinds of things that are out there. These are tools available to us to help people when they make that quit attempt, increases the chances that they'll quit. There was a big concern about the psychiatric effects of quitting and what happens to people's mental health when they quit smoking. And do these medications make it worse? So the FDA essentially directed the manufacturer of varenicline to Pfizer to say, do a head-to-head study. You have to cover all the medications, not just yours. All the medications, do a head-to-head trial in two populations, those with stable psychiatric conditions and those with no psychiatric conditions, and tell us how safe this medication is. Roughly, they came out, one, that the medications were effective, as you would expect. People with psychiatric conditions didn't do as well as those without, but they still did better. And they did respond well to the medications, and the side effects that occurred were no different between the groups. We've done a whole case series looking at our health services data to look at people who were given varenicline and bupropion through our public program and followed them within subject before and after to see what side effects they had, any cardiac side effects or psychiatric side effects. In this patient population, who has a lot of psychiatric comorbidity, we could see no change. Now, it's administrative data set, but that's where it is. But from the cardiac side, we noticed a little bit of a signal in the first few weeks. Now, that could be because they were treated because they had a cardiac event, as to opposed to not. But again, overall, very safe both in randomized trials and other trials. So we've become very confident in using this medication, which is generic, in patients who have psychiatric comorbidity where smoking rates are much higher. So in Canada, our smoking rates in the general population is down to about 10%. Over here, it's now up to with mental health patients with mental health conditions, our prevalence can be anywhere from 60 to 90%, depending on which population you look at. So we're saying we need to use every tool for this population, and that's varenicline has come out there. So the other question is, should medication just be given to people who are ready to quit? And typically in a resource sort of poor place, you would say, no, just reserve that medication for those ready to make a quit attempt. And there's some indication that if you give people not ready to quit a trial where they can start off with this, the experience of the medication helps them make that decision to quit. So we have this protocol called Reduce to Quit. They're not ready to make a quit attempt right away, but they're willing to start the medication. So we start the medication, and with the coming back and the motivational interviewing, they are making quit attempts and getting to that. So that's been another shift in the way of not only getting the people who are ready to quit, but everybody. And the reason why everybody wants to pick the people who are most ready is this. People look at success rates, not necessarily everybody. Now, if you only look at success rates, it's easy as a clinician to game it. You basically ignore everybody else, and you only take people who are ready. But guess who's ready? People with high higher education, high social advantage, and the capacity and abilities to do this. What happens is now you're leaving behind people who have lower cognitive capacity because of head injury, mental illness, whatever other issues or life stressors, and they don't come into your program. So in our clinical program, although we report it as one of the outcomes, it is not the only outcome. We are very interested in how engaged can we keep people in the process of quitting. Is reduction on the way to quitting another outcome, an intermediary outcome? And so we really need to rethink at a clinical level what has been used at population level, which is prevalence reduction, quitting, and what have you. At the clinical level, can you look at something different? So this is how you can mix clinical and population level kind of outcome measures. Similarly with varenicline, so we've been looking at both of giving people, if you're willing to try, you're too afraid to stop, but you're willing to try the medication, give you a bit of a kickstart. If people are not willing, can we provide motivation interviewing? It's very interesting. Motivation interviewing takes a lot of training. And the problem is, if you don't have fidelity to it, you don't know if what was delivered was motivational interviewing or not. But what we have started doing is using a simple skill that any clinician can provide is, even if the person isn't ready to quit, can they make their living, travel, and workspace smoke-free as the first step? And that is setting up that environment so that when they do try to quit, they can be successful. And the second thing we ask them to do is to just track their smoking. We know this from every behavior. If you track a behavior, it creates a reduction in that behavior. It's Benjamin Franklin. He did it first. But it shows up in whether you're managing diabetes or other disease conditions. Monitor the behavior, and the behavior improves. So these are two things that we invite patients not ready. And so we don't exclude people from our program if they are not ready. We engage them, but they engage them where they're at. So that's the other thing in clinical things that we're looking at is if we only take people who are ready to quit, we are ignoring the bulk of smokers who are not ready. And we really need to help them move forward. Of course, evidence suggests brief interventions, all of these things work. The problem is, here's what I find difficult. Even all of these things work. In the clinical setting, what we are saying is one of the most important things that can improve and prevent so many conditions. We are saying spend the least amount of time with it. There's something wrong when we do that. Think about it. Just because it's effective when you do a little bit doesn't mean that that's what we should be doing. We should be putting more effort in helping people quit, because if you help somebody quit smoking, you're essentially reducing their risk of cardiac, lung, cancer, diabetes, a whole bunch of things. So we need to think about it a bit more and not only go with brief interventions. I think brief interventions are good at population levels, but when in the clinical setting, we need to do a bit more intensive. And because greater intensity leads to greater effectiveness. So if you're really wanting to, at a clinical level, I get it, at a population level, quit lines, all of that can be brief. But at the clinic, you want to make sure you have somebody focusing on that patient, because that patient, if they quit, are going to get huge benefits to their health. So now here's the interesting thing. Brief advice is more effective than no advice, fair enough. Counseling is more effective, but you do need some training in it. But the counseling doesn't have to be complicated. It's problem solving. It's helping them engage the patient, set a quit date, have systems and ways to move towards quitting, and monitor them, and re-engage them should they relapse. It's like any chronic disease management. So clinicians, we train clinicians to be able to do that, and it doesn't have to be the physician. It can be other healthcare members of the team that can provide that. Now, motivational interviewing is out there, but I'm not going to spend too much time on it because it takes a lot of specific training. And so if you don't have, in a clinical setting, that ability to train people to fidelity, to make sure you monitor them and help them learn it, you may not get the outcome that you're looking for. And the most recent Cochrane review, because it included all of this, found some mixed data as to whether it's a worthwhile intervention. So I would look at motivation interviewing kind of off the table unless you have specialized training in it and a proper training in it. Because here's the problem with motivational interviewing, which was noticed. People would classify the smoker in the clinical setting as, oh, this person is in pre-contemplation. They're not even thinking about quitting, or they're in contemplation, and then completely ignore them and say, come back to me when you're ready. And so in a sense, they ignored the people who needed most of the help. So we've said, no, if you're going to do that, that's not helpful. And the data suggests that the stages of change is not a helpful way to implement. You need to be systematic and offer everybody help, and offer them help and advise them to quit. So that may be more efficient in a busy clinical setting than doing motivation interviewing. The settings, again, combination of behavioral therapy and pharmacotherapy work better than either alone. So it's really important not to just do one without the other. Some people say we'll only provide counseling. Some people say we'll only provide medication. The ideal setting is provide both. And you could do it in various settings. I mean, the counseling can be in healthcare settings, community-based settings. So think outside the box as to where do smokers are, where they are, and provide the service where they are. So now what else can we do to improve cessation outcomes? There's some evidence for contingency management, which has been very difficult. It's been easy to study, a lot of trials, but it's very difficult to implement within clinical settings because the very nature of it is you're rewarding somebody for not smoking. It can be kind of mindless, right? They show up, you do a breathalyzer, it's below a certain cutoff of 5 or 8 or whatever you want to set it, you give them a reward. It could be a cash reward or something. In North America, there's been a lot of reticence to actually doing that in a clinical program. In the studies, yes, but not in a clinical program. But it does seem to make a difference. And the problem is, as soon as the financial incentive goes away, because it's an extrinsic motivator, there's a high rate of relapse. So it needs further study of saying, if you use this to get a population started, what can you do to help them maintain even after those financial rewards diminish? Another one, which is, there's a lot of the issue of technology. And interestingly, apps have not shown consistently a benefit. But what has is text messaging. So it is a relatively cheaper in terms of development and deployment than apps, which take a lot of time for develop and testing, and the operating system might change, and you have to keep it updated, and then data privacy and all of those things. But text messaging can improve cessation intervention. So thinking about text messaging could be a relatively cost-effective, cheap way to help people quit. Another medication that came on the block, which is not available here, I understand, but it's an old medication, cytosine. Cytosine comes from the laburnum plant. It's a naturally occurring alkaloid. And it's interesting, it's a partial nicotine agonist. So it works like, in fact, varenicline, which is the commercial drug was inspired by this product, natural product. And this was used in Bulgaria for years and post-World War II in that eastern bloc of the Soviet Union. But it never made it commercially to the rest of the world. But more recently in Canada, a company developed it, a pharmacist went and got authorization, and it's a natural product. So, and there have been a couple of randomized trials, and including one published in the New England Journal of Medicine by some colleagues. But basically, what it's showing is that it does seem to do better than placebo. And the question is availability of this drug. It's not easily available. It needs authorization, but it's over the counter. And this potentially has great benefit because acceptability may be high. The downside to it is it requires multiple doses in the day. Whereas with varenicline, it's twice a day. This is 5 to 6 times a day. So people find it too much of a burden to take. Another innovation that's out there, and I was pleased to hear in the earlier presentation today that there's some consideration as well. Our brains communicate 2 ways, right? Through our neurons communicate by chemicals or neurotransmitters, but also by electrical current. And there are patterns on which our brain circuits communicate with each other. And non-invasive brain stimulation, which means you don't actually have to put in a deep probe into the brain, it's given through the scalp, has found actually something called RTMS to be effective. And essentially, the problem is that although there's one which has got an FDA approval called BrainSway in North America, the problem is there's high risk of bias in the trials because it's tough to do these trials with appropriate blinding. And so there's low level of confidence in the results, but there is a signal that this is an area of further development for quitting smoking. The problem is the machines are large, and you have to show up 5 times a week to the clinic for at least 3 weeks. So it can get pretty intensive. So you'll land up with only people who are highly motivated to show up. But it's the beginning. And basically, it's watch this space. But those are some of the things. But more research is needed. Now the big controversial is, are e-cigarettes a boon? Are they a bad thing? Here's the problem. The way the world has regulated it, we've landed up in this weird situation where we've amplified the absolute risk to young people who may have not taken up smoking, are taking up vaping, and may be coming to harm. You're either getting them immediate harm, where they get addicted to nicotine, where they normally would not have, or they're getting exposed to chemicals that are causing lung damage. And there was something called EVALI in the US that happened because it was unregulated, it was contaminated, and it caused significant lung English. This is prior to the COVID pandemic. But they landed up with lung failure, and there were 62 deaths. Every young person you kill, that's huge potential years of life lost. And so if you have a product that is promising to be safer, but is only being used by people who are at low risk, you're not actually improving societal safety, you're actually worsening it. That's one. The second thing is, if the young person now is going to have a long career addicted to a product, what does that impact? We don't know yet. We don't know what the cumulative impact of inhaling flavors and some of the excipients are going to do. We know what nicotine is going to do, but what are those other components we don't know? So that absolute risk has gone up because the way we've regulated it. If we wanted to use it for its relative risk reduction, which is, can we give it to people who smoke, who are not willing or able to take regular smoking cessation, so the 40-year-old or 50-year-old person who's already developed some smoking-related condition, and they don't have an alternative, this is a relative risk reduction for them. But this population is not using e-cigarettes. Why? Because they are hearing the message of how bad e-cigarettes are, so they're staying with their cigarettes. So we've got this weird situation of how these things are regulated, that it's actually paradoxically being used much more by people who are young than the people who could benefit. And these two studies, these two meta-analyses have shown, the first one was the Hartman-Boyd study, and it's been updated in 22, where they've increased their confidence that in populations where you use e-cigarettes, it does have benefit. And it does help people achieve abstinence. The caveat is that the people have continued to use the e-cigarettes, so it's not a short-term treatment, it's a complete switchover. And Eisenberg in Canada did this trial, and interestingly enough, he had to stop the trial halfway because one, the pandemic hit, but more importantly, the product was no longer available. The e-cigarette market is constantly changing, so products may be on the market today, they're gone tomorrow. So you have to, they're not, and that's the problem when you don't have a regulated product on the market. So all of this is, yes, you may have evidence that there's utility, but I talk to my clinician colleagues, they will not recommend e-cigarettes because how do you recommend something that has not been regulated? That I don't know whether from batch to batch the person's getting the same amount of nicotine, different type of nicotine, or what are the safety issues. So if we are serious about relative risk reduction, we need to create the framework where you can get a regulated product that doesn't get into the hands of kids and gets into the hands of adults only who are unable or unwilling to quit. Otherwise, you're stuck with this situation where young people are going to take it up. Now, in many parts of the world, you'll see a reduction in, you're seeing this downward trend in youth smoking in the UK, Canada, and everybody wants to attribute that to vaping. The question is, that downward slope was happening even prior to vaping being taken up. And so we really can't say that vaping is the solution to preventing youth from taking up smoking. But what I can tell you is that the youth who vape are also the youth who are using other substances, at least in Canada. They're using other substances, they're drinking, and they have mental health problems. So if I see a young person vaping, it's my red flag to watch this kid for problems coming along the way. I don't know if that applies here, but at least in our situation it does. Especially the kid who persists, the 30-day regular daily vapor, that's the kid I'm worried about because clinically, that's the kid who's going to have ADHD or depression or schizophrenia or something coming, or they're going to use other substances. So in Canada, where I am, here's an interesting thing. We are a country for harm reduction. We've legalized cannabis 5 years ago. And by full disclosure, I'm on a panel to review the effects of that legislation. We have an 18-month task to look at that regulation. So it's a harm reduction country. We have supervised consumption sites, supervised injection sites, decriminalization of possession for small amounts of opiates, etc. So the government had this abstinence-only approach for tobacco, but a harm reduction approach for other substances. So what was really ironic is the supervised consumption facility where somebody bought illicit drugs, brought it to the facility to consume, had to finish their cigarette outside before they went in to consume their drugs. So this was not fitting well with this harm reduction mind. So the Ministry of Health asked us, can you create some sort of guidance for low-risk nicotine use, given that we recognize that there's a population that's going to continue to use. So we created an evidence brief of how and who this should be used for, and it's basically based on expert advice. It's nothing else. So that is another development in Canada, that we have this lower nicotine use guideline to say, how do you get away from combustible? And very careful in the messaging is that if people are going to make the choice to vape to quit, how they do it safely and how they do it properly so that they don't land up with harms from vaping. And these are some of the tips that have come from people who, the people with lived experience of how they've been doing it, as well as expert opinion. And these are the kinds of things that we, you can download that. That's the other area that we're going with this population. And both things can be true. We actually have guidance for harm reduction, as I said, but we also understand that there's a lot of uncertainty in the clinical side of how to help people quit. So for example, there was a big work as to personalizing the medication. If you've got a genetic test and if you metabolize nicotine in a certain way, you may do better with one treatment or not. But it didn't really pan out, so it hasn't scaled up, and there's more studies required. And so basically, if you metabolize nicotine at the normal rate, you may be better off with varenicline than the patch. But here's the policy issue. Varenicline is not available. So we are forced to give people less effective medication. So this is where we have to work with policymakers, say, look, here's the evidence that we need to do better, and we need to help these companies. It's a generic drug now. Who's manufacturing this generic drug? There's one manufacturer in Canada called APO that provides it, and so we haven't had a loss of varenicline for our patients. But US has, other countries have. So if we are serious about helping smokers quit, then we can't have policies that come in the way of medications being available. Reduction to quit. As I mentioned, it's there, but it's not very popular with our clinicians because all they want is the person to set a quit date, stop, and none of this reduction to quit. It's an all or none. And we are recognizing that this is an option for many, so we should be offering this. There's also the idea of mindfulness, non-invasive brain stimulation, as we talked about, and psychedelics. So there's a huge, I don't know if it's happening here, but there's, in psychiatry, in North America, things like ketamine for treatment-resistant depression and psilocybin are becoming newer drugs for studying that. And there's one study out of, that came out by Johnson in 2017 looking at psilocybin for smoking cessation, but it hasn't been replicated. So these are the areas of research that are going on. But what are some of the ongoing challenges with vaping? Because, as we said, vaping is really a bad thing for young people who would not come to harm from tobacco, who have, prevention, it's amazing, like more than 50% of the population haven't smoked in Canada. And so prevention has worked. So introducing something like vaping to a young population is going to potentially cause harm to that population. So what are some ongoing challenges we faced? So as you know, vaping is a non-combustible delivery of nicotine, which is great. Nicotine is not classified as a carcinogen, so that's good. And nicotine by itself has not been associated with cardiovascular or other detrimental health effects. There are some effects from nicotine, but clearly overall, unit for unit exposure, you're going to get less exposure to toxins from e-cigarettes than that. So theoretically, great. You can compare them, and this has been done in 2014, so it's coming close to 10 years. We've known this, right? That you're going to get orders of magnitude less exposure if somebody gets this. But even that exposure to somebody who's never smoked is not a good thing. So that's why what has happened to our policies whereby it is now being used by young people, but not by people who smoke. I'm not going to bore you with this, but this really tells you what happens to these carcinogens and exposure when people are using combustible cigarettes of how much they get compared to the other things. So basically, this slide tells you combustible cigarettes are bad. And so I don't understand that in this day and age, why it's continued to be manufactured. It's more than 100-year-old technology that is still being pushed upon people when there is a potentially safer alternative. And how do we make that come into if we accept people will use substances, and that may not be true here, but in North America it is, then how do you make sure that people get the safest form of that substance of which they desire that doesn't cause them harm? You can't do that when you're constantly allowing cigarettes to be the easier choice for people in terms of density outlet, availability, marketing, price, all of those things. Can't make sense, but that's what you have. This is the comparative kinetics. If you look at, we often talk about nicotine replacement as the clean form of nicotine. But if you look at the slide, when you're trying to replace nicotine that somebody's trying to get from a cigarette, nicotine replacement, pharmaceutical nicotine, doesn't come anywhere close. So you're getting close to maybe 50% at best. But if you look at these range of vaping devices, you're getting pretty close. So potentially, theoretically, pharmacologically, there's an option here for a switch over. So for that person who smokes, who's unable or unwilling to quit, at least from a pharmacological perspective, if nicotine is what is driving their addiction, you have a safer alternative. That is coming close. Not absolute, but it's coming close. But the problem we all have, as I mentioned, is there's no quality control. The tobacco industry has got into the game. In fact, the common one there is Vuse, which is made by one of the tobacco companies. We've lost it. When it first came out, vaping devices were not tobacco industry related. And the battle was lost to the industry because we, as public health, fought against them. Instead of creating a framework to develop it and keep it out of the hands of the industry, it's now too late. It's gone to the industry. And the industry is hedging its bets. They continue to sell combustible cigarettes. They've created a product that is an interfering product called heat not burn. IQOS is the name. And they've got also these vaping devices. So basically, they're hedging their bets to be profitable. So I think Jason is, if we don't pay attention to follow the money, who's going to make money? Because at the end of the day, the population is the pawn of that, right? So it is important. So as a provider, as a clinician, I find my colleagues and us are very stuck because we don't have a good quality control measure product. We don't have an idea of what the harms of vapor inhalation is, or aerosol inhalation, as it should be rightly called. Is it actually a gateway to smoking? Because people who start vaping, are they switching over to cigarettes? And are they going to do both, which is worse than either alone? And we don't know the long-term context. And the problem is, if you keep this illegal, you can't study it properly. So are we missing out on a potential solution and shaping a potential solution? I'm trying to think about, imagine when we had the first automobile come out and it threatened everybody who were riding horse and carriages. And we said, that's it, stop it. We're not going to do further development. Would we be here today with an electric car? I don't know. So we have got to be really careful when we kill innovation. Are we killing off an innovation that potentially is a solution? And that requires further refinement. And is it better to let the industry define it, or should the health sector be defining this? Should the health sector be leading it? And that's a debate happening as we speak. Nobody's got the answer, but right now I know the money going into it is coming from the industry, not from us, or from governments, or from research. So there's a challenge there. We talked about the low risk guidelines. We talked about people quitting. And here's what I want to get to is, compared to nicotine replacement, they've upgraded their confidence that they have high certainty of evidence that vaping devices are better. This is in the UK. So the NHS actually gives out vaping devices as part of their stop smoking service. So it's very different. We don't do that in Canada. We don't do that in anywhere else in the world that I know of. But it's the most popular treatment being used. So that's the innovation out there. But it's not being rapidly absorbed by the health system across the world. And, the debate still continues. So I'm just going to quickly summarize. That's my team. But what I want to summarize today is that these are the challenges in smoking cessation. We don't have good access for evidence-based treatments from a variety of levels. One is systemic issues like manufacturing processes. Second is coverage in drug plans. Third is the knowledge and the use of it, engaging people, giving it to them for long enough for the doses that they need, and combining it with the behavioral interventions that can work to help them. We don't also couple it with policy level changes that happen. So for example, the price increase that happened should ideally see a bump up in need for services. So was that coupled? So that's why in tobacco control measures, you need all these elements to work together if you're going to get a good outcome. Because that increase in price should increase at a population level number of people who make a quit attempt. Are you there with the services to help them? The other piece that I say is, okay, so you've got this, but then do the clinicians know how to integrate behavioral and pharmacological treatments and help patients quit? And then lastly, we've got these electronic cigarettes on the market, but we've got a policy level that makes it easier for young people to get them than the smokers who are unable to quit to get them. So is that applicable in Singapore? I don't know yet, but it's something to consider, because otherwise you're going to have a bunch of people addicted to e-cigarettes, young people, and make them to harm because they are illicitly produced products. So that idea, maybe you may not have people, many people vaping, but those who do may be getting really badly produced products. So there's a lot of work for us to do to improve those options. So I'll stop and open up for question and discussion. I just want to open up some thoughts for you to grapple with and push back against, and thank you for your attention.
Thank you very much, Dr. Selby, for sharing your insights on this. So Dr. Selby will now take some questions from the floor. There are microphones that are located along the steps, and you may head over to the nearest microphone to pose your question. Do introduce yourself before you pose your question. Just share with us your name and the organization that you are from. Okay, maybe I start first. Yeah. Right, so I think thanks very much for your presentation. It was very interesting. My question is a bit more of, I think you focus a lot on smokers who are pretty much fairly addicted, maybe middle-aged in life. Do you have any insights on the younger smokers, in particularly the youths, especially if, according to the law, they are not legally allowed to smoke, but they are already smoking, and we do want to help them, but there's this gray area of how exactly do they get help without getting into trouble or getting their friends into trouble?
Yeah, I think that's the challenge. Young people are afraid of authority, and they don't generally want to come into clinical settings because they don't see that as that framing of it as an addiction or as a health problem. It's not how they see it. It's something they do. They don't, So the young people who come into us typically are coming to us because of some other condition, anxiety, depression, something else. So that's one population of young people. They'll come because of their other health conditions, either to the pediatric hospital or to the psychiatric hospital for young youth. So that's one way. That's the higher risk population who comes in. In smoking cessation, no intervention other than availability, denormalization, all of those things have worked. But I am curious in this day of social media and all of that, whether those same things will work with the current population in terms of denormalizing when they've got this huge impact of influencers who are showing them how to vape and all of that. I don't know, but I can tell you that we don't have the answer of how to engage young people in vaping cessation at a scale other than at an individual level, like that's happened with the Truth Initiative where there's an app and things like that. But at a population level, at the university level, we have to start from scratch. We can get informed by what worked with tobacco control, but I don't think we know exactly what's going to happen with vaping, because when we talk to kids about vaping, it's not just one device. They'll have many devices. They share devices. They don't know what's in the device. They think sometimes it has no nicotine, then it has nicotine, and it's all over the map. So I think we have to do more foundational research as to what is it going to be and what are the subpopulations that we may need to address. I can tell you about the population that comes in with these comorbidities, but not the general population.
Thanks. So I've had my turn.
Okay, thank you very much. Singapore's government is often described as being a bit paternalistic. So, for example, there are very tight restrictions on where people can smoke in the country. Vaping is illegal, and so I wonder if you think outside of the kind of the box of the liberal environment that you're used to in Canada, and given carte blanche, what would you recommend for cessation measures without those restrictions and in a country where more things are possible, perhaps?
Yeah. So I think those environmental restrictions do make a difference. We know that, and they do reduce the social acceptability and what have you. But the question is what to do with those who continue. So you know, and this is where I wonder whether contingency management would be more in keeping with the philosophy where, you know, there's an outcome, measurable outcome, there's a reward. If that fits with the culture and the availability, then should contingency management be considered at a broad scale? The other thing I've heard is the culture is a lot of with competition. So do quit competitions help and work here, right? So can you use the cultural acceptance and the structures around here to engage? And the other one is social norming. If there's a social norm that can be created, that's the other piece. So, for example, there's a program which was run on campuses in Canada called Leave the Pack Behind. It got lost its funding, but essentially it created a campus-wide initiative which had, you know, young people to lead it. They had booths, they had competitions, and the health services for youth as well, which would provide cessation. So they had this wraparound thing and a culture within the campus, tobacco-free campus, no sponsorship, no vaping, no advertising, all of that for young people. Who it missed were people who are not in university and going into trades. But those are the kinds of things where you've got more organizational structure. Can you leverage it for these kinds of things? So contingency management is the closest way I feel. If you've got a structure that's willing to do that, you may be able to, it's worth trying. And there's some companies now in the US that are trying to develop apps with the contingency management. So it could be scalable broader than that. But of course, that's a national debate to be had. Hope that helps.
Dr. Selby, time's moving on, but and Alex's question kind of covers most of what I wanted to ask you, but I was very intrigued by your last comment about if we increase taxation on cigarettes, we should see an uptick in the take-up of smoking cessation programs. So that's interesting because if we do not see the uptick, the recent price taxation increase wasn't good enough, we can go further. Does that make sense?
I mean, the evidence is there to keep going. The question is there a, you know, who's lobbying them to scare the government? That's the problem. In most countries, I don't know how it is in Singapore, but in other places, immediately as the tax increases, you know, there's the boogeyman of, oh my God, contraband will go up and bad things will happen. And, you know, but the evidence is pretty strong. You increase the price elasticity is there, so keep going till, I mean, you know, you can't do a price increase once in 10 years and then forget about it. It's very hard in Canada. We've been trying to get them to increase it, but it's, again, you know, they don't like to do targeted taxation, like where they'll target the tax and then reinvest it. They don't do that. They're very slow. They'll put a little bit, but it's not enough to be perceptible. All of those kinds of things. So, you know, there's a whole bunch of people who call it regressive taxation. So you get this mix, despite the evidence. And here's how I balance those two things. Yes, absolutely, it may be regressive, but create an out for the person by providing cessation services. So there's a, you know, so you can mitigate that effect. You're not telling people you're on your own. You're saying, okay, fair enough. We know this works. It's going to increase your motivation to quit. And here's a way out.
Are there any further questions from the audience?
Okay.
Okay, I guess if not, thank you very much, Dr. Selby, for sharing your insights with us today. And before we wrap up the session, I would like to invite Professor Yap to present a token of appreciation to Dr. Selby. And additionally, we'd like to invite Dr. Yvette to join them on stage for the photo taking. This calligraphy scroll that they are being presented with is a replica of the memento that's been presented to our school's benefactor, the late Professor Saw Swee Hock, when the school was officially established in 2011. Ladies and gentlemen, the Chinese characters on the scroll, when read from your right to left, 人人健康, means health for all, underlying the school's commitment to turn discovery into healthier communities. The very same characters, when you read it from the left to right, 康健人人, means all for health, highlighting how good health provides a critical foundation for a strong population. Thank you, Dr. Selby and Professor Yap. We have come to the end of today's Public Health Thought Leadership Dialogue. Thank you very much once again for joining us. We invite you to follow the school on our social media platforms, I think LinkedIn and Instagram, via the QR codes on the screen so that you can be kept up to date for our future events. And once again, thank you for coming to join us, and we wish you good health and good evening and a good rest of the week.